I'm really pleased to be introducing now the panel discussion to close our session. And our panel, as you'll hear when people introduce or reintroduce themselves, bring a wealth of experience and expertise from different backgrounds. And we'll be thinking together towards a broader question, which is what needs to happen now to make mental health care acceptable and effective for autistic people? What are the challenges and what is going well? And we'll be approaching that first by putting a series of individual questions to our panelists. We'll then be drawing together some overall reflections on our theme and then opening out to audience questions. I'll reintroduce myself first. So I'm Richard, I'm a clinical psychologist and autism researcher.
I'm Amanda Timmerman, I'm autistic with co-occurring health conditions. I'm a lived experience researcher on this project, and I'm a part-time PhD student at UCL with a focus on autistic adults and quality of life.
Hi everyone, I'm Lorcan and I'm the National Research Lead at NIHR England. You've already heard about my background, so I'll leave time for others.
Yeah, hi everyone. My name's Dr. Chris Papadopoulos. I'm a Principal Lecturer in Public Health at the University of Bedfordshire, but I also created and run the London Autism Group charity. So I do a lot of front-facing community work, and I'm also a parent-carer of 2 autistic children.
Hello, I'm Robin Jackson. I am autistic, and I'm a lived experience researcher on this project. I'm also a CAMHS mental health nurse in Lancaster.
Hi, I'm Eva. I'm also on the lived experience group on this project as a carer. I'm a carer for Alex,
Hello.
Who was diagnosed 10 years ago with autism. And when I'm not doing this, I'm caring for 2 other people with mental health problems and working in a part-time admin job.
Yes, my mum introduced me a little bit. I'm Alex. I was diagnosed at 13, so I have fairly recent experience of mental health services, especially for children in London and the UK. And I've been invited to join this panel even though I'm not part of the ongoing research project.
Brilliant. Thanks so much, everyone. A warm welcome and thank you. We're going to move on to our questions, and our first question is for you, Eva and Alex, together. Would you be happy to speak to what is your experience of mental health care for autistic people?
I'll start a bit. I think that we have, as a family, we have bipolar disorder, and then my husband, that's Alex's dad, and then 2 children who were diagnosed with all sorts of different things, but ultimately with ADHD and anxiety and autism. So we were in contact with mental health services for family support about 15 years ago, and then Alex was referred to CAMHS, and we were lucky that we got straight through, really, when she was in primary school, and there were a couple of really very bad years. I think we're a case study for what Richard was describing, really. Alex's mental health deteriorated quite badly when she went to secondary school, and she became a school refuser. She was given different kinds of therapies at CAMHS, including psychodynamic psychotherapy, which after 6 sessions the therapist said that he couldn't work with her because it was like talking to an adult at a dinner party, which is, I think, scripting and very common, that she was saying the things that she'd heard us adults say. And then another therapist who's doing CBT abandoned that after 1 session, saying that Alex wasn't able to access and express her feelings. And I, at about the same time, heard something on Radio 4 about autism in children, and particularly in girls, and so I suggested to CAMHS that perhaps autism was the issue here, and she was diagnosed with autism. So one of the main points I'd like to make, which has come across from nearly every talk, is about diagnosis and about education of people within mental health services. And I think environment is the other really, really big issue here, because at school, at secondary school, Alex was crying every day, morning and night, unable to say what apart from school, 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 over and over again. And as a carer, that was really difficult for me because I was being given advice that she had to go to school. I was dragging a sobbing child to the bus stop every morning, pushing her into school because I was being told that by the school, by mental health services, by the local authority, and I didn't have the confidence as a carer to listen to my own gut and say this is wrong, although eventually I did, pulled her out. She found a fantastic school. But the whole thing went over again when she moved to sixth form and things got worse again. So I can see the hovering with my time's up, I think. But Alex's mental health was really problematic when the environment was wrong. So she went to 6 different schools, and in 3 of those she thrived, and in 3 of those she struggled. And it came down to the attitude of the school being supportive of Alex's needs, in some cases when we didn't have a diagnosis for her, but allowing her to be the person she is. And then she thrived and was academically very successful. Are you happy to take over now from that?
Oh, yes. Yeah. Do I get a bit?
Yeah.
Ah, I get a bit. That's so exciting. Yeah, so you mentioned it in terms of CBT, in terms of what people could do in actual therapies, in terms of the mental health services themselves, things like environment, how people communicate, what assurances have been given to autistic people to make sure that they know what's going on, they have a good schedule, they have timings, there's no background noise. And a lot of that, once that was fixed, once I trusted my school to be able to do those things for me, often without me having to ask, but if I asked, they would definitely be fixed, made a huge impact on my ability to just function every day. But as soon as I ended up going to a really excellent school, and the Senko there, I trusted her completely. She was like my school mum. And I would just, if I was stressed, if I was unable to cope in a lesson for any reason, I didn't even have to tell the teacher I was leaving. I was allowed to just get up and leave and go talk to her, and we'd talk about parrots or whatever it is I wanted to chat about that day. And that really, really helped, that I had a safe place to go, someone I trusted to talk to. And then once I trusted her, all the other staff that became trustworthy, and the whole place became fun. It was nice. I enjoyed my time there. I was still stressed. There were things that caused problems, but generally it felt safe in a way my other schools never did. It felt like I was somewhere inhospitable, and I never liked that. I ended up going to a sixth form because the physics teaching at my school was not as good as I'd hoped it to be, and I really liked physics, so I went somewhere more specialist. But once again, I didn't feel safe. There was no... If I was having a bad time, that was my problem. There wasn't anything I could do. The subject teachers and the students were excellent, but there was no support from the school to the point where they were actually getting... what was it? They were being told by...
There was a punitive regime at the sixth form where at the previous school, if Alex struggled, she was allowed to leave the classroom and ultimately the school if she needed to on a particular day. But at the sixth form, they had a great strategy. They wouldn't listen to the CAM support or the psychiatrist, and their idea was that Alex would be put in a room on her own for half an hour. They'd come in and ask her to go back to the classroom. If she couldn't, they'd come back at increasingly smaller amounts of time, so 20 minutes, 15 minutes, 10 minutes. It was like a terror regime, and they wouldn't listen to anybody. And Alex's mental health problems then all reappeared because the environment had turned hostile again.
And eventually I left after most of a year and went back to the school that had been so brilliant before. And once again, I managed to do my A-levels. I did really well. And then COVID and university and all sorts of other fun things.
Often it comes down to a key person in our experience, the person who understands and can support and has the authority within an organisation to provide the right support. But Alex has just graduated, so things are looking good.
Brilliant. Thanks so much, Eva and Alex, for sharing those reflections. I think it's really important to consider just how important those environments are, and I think you've really helped bring that to life for us. And speaking about your experience with your school mum was lovely to hear about as well as your relationship with your mum, who's here with you as well. That I think leads us as well nicely on to the next question, which is about barriers to mental health care, which is for you, Amanda, if you're happy to. What are the barriers to mental health care that autistic people face?
For my response, I mostly will focus on accessibility and like my personal experiences with it. So in the first instance, if the GP is the first point of call, how do you actually access the GP is through the receptionists. And some receptionists are lovely, they're friendly, they're professional, but then you'll get odd behaviours from others, which can be quite discouraging if you're there to seek help. So I've had like a receptionist stare at me intensively while I was in the waiting room once with no kind of reasoning why. I've had a receptionist challenge my choice of GP, where I've tried my best to just kind of say, you know, use whichever GP is available, and then, but if I ask for a specific one, I've been challenged before saying we have other GPs, you know, so it's like these unhelpful things make it really difficult to access support. Sometimes as well, with the kind of receptionist experience, it can be very unclear to like how to kind of socially navigate that interaction. So like if a receptionist is working on their computer, or if they've just come off of a phone call, or if they're talking with a colleague, it can be very difficult to actually know when it's my turn to talk, unless they say, oh, hello, and then kind of invite the conversation. It can be very difficult to kind of, yeah, there have been times where I'm just standing awkwardly there waiting for the right moment to kind of receive some customer service, to access making an appointment and getting to see the GP. Phones being a very big part of accessing care is a bit of a challenge. For me, that's like my least preferred contact method. It can trigger anxiety. Just my reasoning behind what kind of fuels that anxiety. There's, when you're on a phone call and they can't see your face, there's pressure to respond very quickly to what's being said. So you don't really have a chance to kind of prepare a response. You're unable to kind of visually communicate if you need more thinking time. So, you know, if they can see me visually, they can see I'm thinking, but if I'm on the phone, there's just this silence, like there's this sudden pressure to fill because of their social expectancy. It's also difficult because I can't interpret the other person's mood, their emotions, what their body language is doing. So it's almost like I'm trying to navigate the social interaction like blind. So there's all this uncertainty, which then leads to anxiety. And then in turn, poorer well-being when I'm there to try and seek support for well-being. And that can happen with IAPs, which is now called NHS Talking Therapies, again with the receptionists, or so anything where there's oftentimes just phones is like the only option to really communicate. And they'll say, oh, you'll receive a phone call. And it's like, that's really not the best way for me to communicate. So oftentimes I'm more likely to fail to communicate, so I might put off important phone calls, and that can be very problematic. As I mentioned, if I'm juggling other health conditions at the same time, I'm less likely to be able to manage a phone call, and that might be the very time when I need to communicate. There's also issues surrounding the shorter-term interventions. In one of the talks it came up that shorter-term interventions, though they are quote-unquote evidence-based, they're very difficult for an autistic person to manage because there's limited time to establish that kind of familiarity and rapport with your therapist. There's like a limited time to explore interactions between your mental health issue and your other health conditions and being autistic. For me, I'm also more likely to mask for the majority of those short-term sessions just because there's this pressure to have a positive social interaction, and it takes time to like drop my own barriers, so meet myself as a barrier to accessing that kind of support. And then the last thing was there's no real kind of structure or practice in place at the moment to find help to navigate those services. So, for example, your family member might not always be appropriate to help you manage things like phone calls, but there doesn't seem to be like an alternative. So it's either like a family member handles the phone call, or I will handle the phone call, or navigating all the forms and systems to try and access support. So there's this sense of there needs to be a facilitator, but there doesn't really seem to be that role in existence at the moment. And I think that's about it. Yes.
Thank you. Thanks so much, Amanda. I was particularly struck by what you were saying about phone calls, actually, because I think it's easy to understate just how important that really is to people, isn't it? Just being put on the spot, the difficulty of navigating that, and just what a big difference it can make for people to offer alternative forms of communication and reaching out to people. Thanks so much. I think that also leads us on to thinking about support and what might be helpful. So, Robin, the next question is addressed to you, if you're okay with that. And what do you think would be useful to support autistic people with their mental health? Thank you. you.
So I think we've covered it a bit already, that the environment is so important. So when I'm thinking about supporting autistic people, a lot of the things that come up in the research are about changing autistic people to make them better fit the environment that they're in. And there's not enough about changing the environment to benefit autistic people. So thinking about healthcare systems being understanding, because maybe if GPs and receptionists understood that I am not going to make that phone call, and if the phone rings, I'm more likely to throw it across the room than pick it up, that then there might be alternative options, like here's an email address you can use, or here's a number that you can text. And the same with thinking about what the environment that people are coming into is. I know that where I work, I wouldn't want to be a patient there. It's really hard working there, and I can only do it because I wear ear defenders. The buildings are old. They make loads of noises. So if we can change where we're offering support, and whether that means we're doing some more virtual support, whether it means we're allowed to shift so that we can go out and meet people in their homes or in places where they feel comfortable, I think that would be really helpful. And also, it's about having that understanding of autism and recognising how much autism impacts on a person, because I think that in mental health, we don't always see the trauma that is caused by having to mask and having to adapt to an environment that you don't, or that is set up against you in a lot of cases. And if we can recognise that, and people can focus on, okay, you're autistic and this is how that's impacted you, and this is the support that you specifically need, that would be really helpful. And I also feel very strongly about this. In a lot of the research, they'll teach social skills to autistic people. Well, I think they need to teach social skills to neurotypical people, because I can understand autistic people really, really well. I'm not very good at understanding neurotypical people, and they're not good at understanding me. So why should the onus always be on autistic people to adapt, and not on neurotypical people to just change a tiny little bit to be a little bit more understanding? And if we could change that, I guess I feel like I'm talking more about things that need to change as a society than things specifically in mental health, but that's because I feel like if those things shifted, there wouldn't be that massive disproportionate amount of autistic people having mental health difficulties. And more specifically to mental health, I think it's really important that we have those autistic therapists and autistic practitioners in mental health services. And I think that covers it. Thank you.
That's brilliant. Thanks so much, Robin. I fully support the idea of social skills training for neurotypical people, to be honest. Yes, how to communicate sensibly and say what they really mean. Yes, absolutely. Lorcan, could you tell us a bit about what NHS England's been doing to improve services? Obviously, you did speak very much to this topic earlier, but if there's more that you'd like to add about, NHS improving mental health care for autistic people. Thank you.
Yeah, certainly. So I guess the first thing is kind of obvious, in that the National Health Service is very large and very complex. So often we might know something that could help, but making it happen in reality is quite a lot harder than it appears on the surface. So an example might be, we know that having phone calls is a barrier to access for autistic people to lots of services. But getting primary care to universally make sure that you can access an appointment without a phone call takes quite a lot of work, and quite a lot of changing processes and systems, and there's companies involved who are designing the interface that people use to access an appointment, and they might be quite rigid, or they might have reasons for doing things the way that they do. So often a lot of the work that we're doing is about something like that, which seems obvious and straightforward, but actually might take a lot of time and work to ultimately change. And so that might be trying to create influence through other organizations. So it might be policies come to us from government departments for us to comment on, and they might not be autism-specific policies sometimes. So pointing out, if someone says, here's a new policy about booking appointments in primary care, we might have a look at it and say, oh, just before this goes out, you please insert this paragraph about access for autistic people, because there might be a paragraph in there about access for people with physical disabilities, and they just forgot to include a paragraph for access for people who might have a communication or sensory related disability. So those are some of the things in terms of with government policies. It's about keeping it on a national policy agenda. Sometimes it's pointing out something that someone didn't think of. But also it might be with other arm's length bodies. So for example, we're working quite closely with the National Institute of Health and Care Excellence, or NICE, to try and update their clinical guidelines, because they haven't been updated in quite a while, and that is the thing that dictates the evidence that's used in practice. It's also working with the Care Quality Commission, who are the regulator of many, but not all, healthcare services for autistic people, to try and see actually can we improve the way in which assessment for autism in independent providers is regulated, for example. You know, that could be another thing. And often people will come to us and say, well, what are you doing about access to mental health provision? And we'll have to redirect and say, well, some of what we're doing is specific to mental health, but some of what we're doing is actually making access to a valid, trustworthy diagnosis more accessible to people, because there can be issues if there are too many diagnoses out there that are not being trusted, that then even if you do have a trustworthy assessment, people will find an excuse to draw into question, well, I don't know if I trust that because there are too many providers out there that we're not trusting the outcomes of their assessments, and therefore they might get denied adaptations that they are legally entitled to. I guess the final part is what I spoke about earlier, is we do work on documentation ourselves within NHS England about instructions that go out to integrated care systems and integrated care boards to try and bring about a kind of a systematic and strategic thinking. So I think often there's a need for that local strategic thinking about, well, we've got a certain amount of need in this particular type of service. The only way to change that is focusing on this service, rather than actually strategically, it might make much more sense to focus downstream and say lots of people are ending up in these services because we don't have enough of the services at the lower levels. And actually, rather than saying let's always focus on inpatient care, let's say if we focus on care outside of hospitals, we might have less need for care in hospitals.
Brilliant. Thanks so much, Lorcan. Yeah, I think it was interesting as well to notice a theme across your and Robin's speeches, both of your answers kind of touching on, when we think about improving mental health services, we often think about the direct sort of delivery at the front line, but actually thinking about the broader societal context and the structures of systems is really useful. And Chris, the last question is for you, if that's okay, which is about what research needs to happen in this area.
Yeah, gosh, big question. I've got lots of thoughts on that. But, you know, I'd say the most important thing when it comes to research, in my opinion, is it's got to be led by autistic priorities, you know, by the autistic community themselves. Like, what is it that they value? What are their priorities, as opposed to the, you know, the kind of more generic academic community? Now, I believe in co-production. I think that's very, very important. But I almost feel like research needs to perhaps like take autistic perspectives and values as first, as priority, as opposed to, you know, alongside neurotypical researchers. So even going further than co-production is something that I'd like to see. Now, if researchers would do that, they engage with the autistic community, well, I think one of the things they'd see, which is something that I see very, very frequently as my role in our charity, where we're meeting autistic people regularly in the community with real mental health problems. I think one of the things they'll see, among many things, is that the probably key issue when it comes to mental health is internalized ableism and internalized stigma. And this is the idea that autistic people themselves perhaps have a negative, you know, it could be a subtle or less subtle negative conception of their own autistic identity, because they're not understanding the neurodivergence or neurodiversity elements, but they're sort of almost victims of the pathological medical deficit conceptualizations that psychiatry is winning out in our social kind of discourse in autism. And this creates poison for mental health of autistic people. And I think I'd like to see more research focused on this. Now, there was a fantastic study, you should all have a look at this, that was released last month in Frontiers in Psychiatry, I think the journal was, by Dr. Seb Shaw from the University of Brighton. And they pretty much conclusively proved my point with this, in that what they did was that they surveyed 220 autistic doctors in the UK, and they asked them questions about their mental health. And one of the things they asked them was, how often have you considered suicide, and how often have you actually acted upon that? And 77%, I think it was something around that mark, had said that they had considered suicide, and about 25% of them had said that they'd actually attempted suicide. 25% of this nationally representative sample of autistic doctors. Now, when they looked at the predictors of why these doctors were considering suicide or had acted upon it, the key predictor was internalized ableism, specifically measured by their view as to whether or not they felt autism was a disorder or a difference. Now, the doctors that had connected it as being a disorder had a much stronger likelihood of suicidal ideation. And there's no bigger mental health problem, probably, than suicidal ideation, right? So one of the things, among many things, is the prevention of that. I could go on, but I'll stop there. Thank you.
Brilliant. Thanks so much, Chris. That's a really interesting study you mentioned there. I'm going to go straight away and look this one up. It's very important. I think that we've all spoken, well, I say we all, I haven't so much, but we've all, as a panel, spoken to our overall theme. But I would like to briefly just invite any other reflections speaking to the overall theme, perhaps if your individual question left other things unanswered that you'd like to speak to. So our overall question is, what needs to happen now to make mental health care acceptable and effective?
Can I just say very quickly, just with regard to that, it came up a couple of times during the talks. I think one of the commentaries that Tamara showed mentioned it, and I think you mentioned it as well, about the importance of autistic mental health therapists themselves. Now, we're looking at your research, you've done a phenomenal comprehensive search of what seemingly has been done when it comes to mental health so-called treatments for autistic people. It seems to me the whole or the majority of the evidence base is built on neurotypical evidence. Even if there's some co-production, the evidence itself tends to be, the mental health therapies are originally built on neurotypical evidence, and then now they're trying them to see whether it fits for autistic people. And this just does not work. Again, with my work with the charity, we've been told repeatedly that generic mental health services like CBT cause real harm. I think it came up in one of the earlier presentations. So we've got to move away from these traditional neurotypically built mental health therapies towards autistic, real evidence built on autistic communities if we're going to get this right. And just to say finally, I really am a strong believer of getting autistic mental health professionals or identity professionals to sort of to take that forward.
Yeah, that's really helpful. When I was at the BABCP conference recently, the Autism SIG is a really positive development within that community, where there are a lot of autistic therapists within the BABCP who are coming together and increasingly shaping that research agenda, which is really positive to hear. Do others have other thoughts at all on what next? Just sort of summarising before we move to our audience questions.
I think just staying on that point of more autistic therapists would be amazing. I just really want to point out that it's really, 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 really hard to do the training as an autistic person, because going into nursing, I think I've lost count of the number of times I was told that maybe I should consider a different career choice because I'm autistic. Maybe I need to work on reducing my reasonable adjustments, because that's just not going to work. I need to be able to do things that I can't possibly do, so you have to do experience on locked wards even when there's fluorescent lights and they're in ancient buildings and you have to do 12-hour shifts, and I just cannot cope with that in order to qualify, even though you want to work in the community with children where you do 8-hour days. So I think it's all part of the bigger picture of what needs to change.
Absolutely. I often think that as part of training, there needs to not only be better adaptations put in place for people, for autistic people to be able to train in a range of professions, but also better mandatory training for people who are not autistic around that as well. I think I cannot see anybody else that seems to be itching to either. Yeah, do go ahead.
Can I just speak briefly about being a carer, because I didn't quite get round to this, but I just wanted to say that we're often trying our best, but we're often lost and ignorant in mental health service, which are labyrinthine in adult and child mental health services. And we end up taking advice from professionals who turn out to be wrong. And it leaves us very isolated and struggling to take care of very, very distressed people, and has quite an impact on our own lives, really. And I think alongside autistic people, we need carer involvement. And often we're painted as the villains, you know, by schools. So the suspicion is that, you know, carers are just damaging the children rather than doing the best they possibly can. And I suppose what I've learned is that, from my own experience, is to fight harder, fight earlier, and trust my own gut and not listen to what everyone else is telling me.
Brilliant. Thank you all very much for speaking to our overall question. And just like to invite audience questions now. If I could ask that please address your question, if possible, to the whole panel so that our panellists don't feel overly put on the spot, that would be appreciated. Yeah, please go ahead. A microphone is on its way.
Hi, I'm Nafiso. I'm a carer of an autistic son as well. My son has severe form of autism, so I was just curious in the research we've all carried out or your experiences. I know a lot has to be done in terms of adapting services in general for autistic people, but has there been anything that looked at the different levels of autism, and is there differences in the needs for people who are what they used to call more high functioning autism? My son, who the environment would impact him a lot in terms of someone to the forensic lights and fluorescent lights and his communication. So he's at one word level now, so he will need his communication to be adapted using picture exchange communication or his caregiver. So he's a big boy now, so when he exhibits challenging behaviour, I worry that if he used mental health services, would they realise that sometimes it just takes speaking to him in a certain way or telling him what's happening really, what's now and next. So yeah, my question is that has research looked at the different levels of autism and what needs to be done for people who have more severe levels?
I'm not entirely sure as to the research evidence base, if I'm honest, when it comes to the different types of support needs. I mean, but I think, you know, having looked at, for example, the work that Tamara did in her review, it seems to be that generally the evidence seems quite unreliable and weak throughout the whole field, right? I mean, one of the things you found in your review, I mean, you looked at pretty much everything, and one of the things you concluded was the quality of the evidence was weak. So even if there was a little bit of research on this, I think we have to be a little bit careful as to, you know, what exactly it's saying. I think ultimately you just need to, as you said previously, you know, trust your gut as to whether or not the service is appropriate for your child. Do you know what I mean? And they're being tailored, they're autistic-led. I think that's one of the key things for any services. Are there frontline autistic voices and people that really get it, you know, and who've got the experience, and also that they're listening to you as well. You know, I think I agree. You know, carers, we do sometimes get sort of almost stigmatized in our own way, but actually we know our child better than anyone, and in fact, the number one likely reason a child will progress is ultimately down to the support that their parent or carer will provide. So the parent and carer plays a crucial role. So does the service work with you? Is it autistic-led? Is it tailored? And do you feel that your child is making progress? I'd go with those kinds of feelings rather than the quality. Unfortunately, I mean, this is the problem. The quality of their research seems very poor at the moment. You know, am I right, Tamara?
Yeah, I was going to add, this works. Oh, it does. What I saw in the studies that we included, so let's say when they were looking at eligible participants, they would determine whether there was a diagnosis, for example, and most of them excluded people, for example, with intellectual disability. And then they didn't actually report on kind of severity of autism either. So it was treated as like a binary outcome in the study. So I would say there is definitely that gap of how these interventions that are being tested, how effective are they for people on sort of different sides on the spectrum, because autism is not a binary thing. Yeah, that's kind of, there's a lack of literature around that, I would say.
Avoid behavioral-based therapies, okay, please. Yeah, that would be my other main advice. Thank you.
Can I also invite Eva to
Just briefly to add about the sensory issues, that when one of the schools Alex went to was so overcrowded that lunches were eaten in the classroom, and Alex couldn't deal with the afternoons at all because the classrooms were smelly and sticky from lunchtime onwards. That was big, wasn't it?
Oh, I hated it. Every classroom always smelled awful all afternoon of 30 kids' lunch that was eaten at tables, and then things would get spilt. You know, people would spill a whole pot of yogurt on the table. I think it was really funny to get random assorted other bits of food and dump it in there, and then they just leave for their afternoon lessons because it's not their job to clear it up, clearly. But it wasn't anyone's job to clear it up. That's just how the classrooms were for the afternoon, and it was awful. And I really, really hated that, and it meant that you couldn't get away from the other people as easily. There wasn't sort of a place that everybody went to and then I could sit in the classroom. There wasn't a cafeteria. Everyone was in their classroom, which meant that every room in the school was full of people, and all the hallways were crowded because everyone was moving between every place constantly. And it was, obviously I'm reasonably high functioning in society, especially now that affordances have been made, but certainly I hope that through people like me who can explain my problems quite clearly and try and really push for changes to be made, that those changes can be given to everybody, because, you know, it's if the lights are bothering me, then they're probably also bothering every other people who can't as easily express their problems. I don't know.
And I think temperature as well. Alex really, really hates the bus, and I think a lot of that is smell and physical discomfort in terms of temperature and light and sound.
We've got 2 questions from the online audience, I think. So, Nat, do you want to start with one?
So we've got a question here. Is there a need for a separate diagnostic tool or tools for assessing depression amongst autistic individuals?
I would say yes, absolutely, because as we've been saying repeatedly throughout this talk this morning, looking at the evidence, everything is built on the neurotypical world, you know, including, you know, the typical depression assessments, you know, like the BDI and whatever else, the Beck's depression inventory and so forth. I mean, they're all built on masses of research evidence, but those in the research, it's neurotypicals. As far as we know, anyway, there was no delineation with autistic people. So, yeah, I'd always support something like that. Yeah, I would agree. Yeah.
Robin, I know.
A lot of the questionnaires, I was diagnosed with depression a few years ago, and a lot of the questionnaires you get given, they're just huge tick box exercises. You get question, and it's slightly agree, largely agree, or how often a week you do it. But a lot of the questions, I know someone mentioned earlier that I feel empty, and it's because they were hungry. And it's exactly that sort of thing. It's how often do you think about death? Well, yesterday I saw a dead rabbit, so I was thinking about death. But that isn't what the question means. But when I was 13, that's what the question, it asked, how often do you think about death? Death is a large part of the reality of everyday life, so I think about death often. It said things like, how often do you think about suicide? Well, sometimes I sit at home and I wonder, what would happen if I was to die suddenly? Well, I wouldn't get to finish my book, so that would be bad. And that's the end of the thought. But that isn't suicidal ideation. That's just how my brain thinks about things constantly. But it's very hard to differentiate on big questionnaires that you're being asked to fill out in the reception of a CAMS on a 3:30 on a Tuesday afternoon, what these questions are trying to ask you without actually asking you that. And I think that that is often misleading. And I was diagnosed with depression, and I did have depression, so it was correct. But I think a lot of the things, I didn't really know what the questions were asking me to do. And a lot of them answered things that in hindsight weren't what the question wanted me to be answering.
Going back to something I said earlier, it often comes down to the right person. We had an amazing CAM psychiatrist who looked after Alex for 8 years, so knew her inside out and was really supportive. And I know we're incredibly lucky to have had that. But she would be reading between the lines and knowing Alex as well.
I would add as well that I think there's a degree of complexity to it, because obviously there's potentially a benefit of having a standalone different measure. But there can be potentially a downside to that too if you have a measure that is mandated for use in the health service. So you have information on this for everyone with a particular diagnosis except for autistic people. It then makes it impossible to make a comparison to say what are the needs of autistic people relative to non-autistic people. And that can be particularly the case in things like NHS talking therapies, which was previously known as IAPT, which is very protocolized and very formulaic. And that's in some ways why it's as successful as it is, because it's delivered in such a standardized way. And in order to be eligible for support from that, you need to be meeting their definition of caseness, as it's referred. So, you know, you've scored above a particular threshold on a very standardized instrument. And so if we try and advocate and say, for exactly the reasons that Alex has explained, some of these questions might be problematic for autistic people, one kind of response you can kind of get is, well, let's assume autistic people shouldn't have access to NHS talking therapies. And we say, no, 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 that's not what we're saying at all. What we're saying is there might be a misinterpretation of the standardized questions. And they say, well, our approach is standardized and that's that, and we can't change it. So instead it's about understanding is the best approach to have a different measure, or to have the same measure with somebody supportive sitting next to you who can explain what's actually meant by the question, or that it has a cover document over it saying, this is the wording, but actually there's a few misinterpretations possible. We don't mean this, we don't mean that, we don't mean this. So then the person reading it can kind of fill it in with that additional knowledge. And in some instances, it might be the case that a different tool is best, but in some cases, it might be the case that a standardized tool, but with additional reasonable adjustments, is preferable because it allows for the comparison across other groups and it fits within the system that's quite immovable and hard to change.
Yeah, and just I think you're right. I think you make a really good point there, Logan. Just to say that, you know, it could also be that you use the, I do think it's important to have appropriate questions and measures. Do you know what I mean? I think there's an ethical importance associated with that is above the sort of protocol standardized needs, although I agree that's just the world that we're in. But the questions do have to work for the right people. So what you could do is basically, you know, adapt it or create an autistic specific depression tool and then bootstrap the results to work for whatever the threshold levels are for the typical depression tools. I mean, there's statistical ways you can deal with that, but I think at point of question, I do think it's important to have the right questions in the right way. So, but you raise a really good point. I agree.
Could I just double check, Robin? Were you keen to get in?
I have a thought,
okay.
Which is just, it's not always just the misunderstanding the questions or the wording being really ambiguous, which it absolutely is, and I also answered in very similar ways. But it's also that they'll ask you what you're feeling and you don't know.
Yeah, intersection.
And so if you don't know what you're feeling and you've got something that's asking you to try and identify feelings, or it's asking you about thoughts and the way that you think isn't in words, it's in pictures, or it's in colours, or it's just not entirely verbal, but more abstract. You know, you can look through these forms and you can just pick answers because you think this is what this wants me to say. And I know that I'm feeling bad. I couldn't tell you what that bad is, but I need to tick this box because then it will tell you that I'm feeling bad, but it won't tell you anything more than that. And I think we need to think about that when we're thinking about developing measures, and we definitely do need to have different measures for autistic people.
Just a really small comment. Lorcan mentioned having someone who you can ask if you're confused about the questions. I was never aware that I was confused about the questions. I thought I had a perfect understanding of everything. Some of them were confusingly worded. Some of them I genuinely didn't know what they were asking. But questions like, do you think about death? It was a straightforward question that I answered truthfully. And I didn't realize until a lot later that I'd misunderstood what the question was trying to ask me. I wouldn't know to ask, what is this question trying to ask me, because I thought I'd understood it. And going through every question with someone explaining it to you, those questionnaires are long. That would take a really long time, and that would stress me out more than just getting it wrong. I don't know. It's a very complicated problem, but it's a big problem in my life that I don't realize that I've misunderstood things until far too late.
That's excellent. Thank you so much, everyone. I think I'll just do a checking with you about the time, Tamara, or should we? Okay. So have we got time to take perhaps one more question before we finish?
Okay, I've got another one from online. It says, research is showing a strong link between autism and gender diversity. Can any of the panelists speak to the specific needs of gender diverse or trans autistic people in mental health services?
Yes, and there's not, I mean, I think you're doubly disadvantaged because there's still not enough understanding about gender identity needs in mental health services anyway. There is starting to be more training, which is good, but I know just from the conversations that I have sitting in the staff room as a non-binary human, that people just don't get a lot of things, and they don't get why it's important. And then when you add on top of that an autism diagnosis, people can start making assumptions like, it's not really a gender identity issue, it's an autism issue. Which, that is part of a much bigger debate. But what it means is that then it's another barrier in getting the care that you need, because people can try and focus on, you came into service because you have anxiety. We're going to do a CBT stepped approach to deal with anxiety. We're going to ignore the fact that a lot of your anxiety comes from your gender dysphoria, or the way that people see you versus the way that you feel, or the fact that gender as a concept makes not a whole lot of sense a lot of the time. And so then you're coming up against that being another thing that's being ignored, as well as we're not taking into account autism and how that's affecting you. But I think in terms of what services could and should do is that if you're autistic, then your experiences of being trans are still your experiences of being trans, and we should still be respecting you as a person and using your preferred language, using your preferred pronouns. Thinking about, I think sometimes when you're autistic and you also have gender identity questions and you go into mental health services, they want to talk about your gender identity and they want to work out whether that's part of your problem or not. Are you really questioning your gender identity? Are you actually trans, or are you just autistic and you saw something online? So I think it's really important that services ask the question of, is this something that you want to explore? Is it something that you want to unpick in mental health? Or have you embraced your identity as a trans person or as a non-binary person, and you just want us to respect that and to focus on the problem that brought you into service? I hope that kind of answers the question a little bit.
I think it does. Thank you.
I add a bit to that. Yeah, so hi again. I'm non-binary and identify as she and they. Heavily socialized as female growing up because of cultural pressures and religious pressures. And then there's that kind of sense of there's alexithymia in there, so difficulty trying to figure out my own feelings around things to do with gender, and obviously if I've got mental health issues alongside that, then it can make the entire process of accessing and receiving support quite complex, because gender expression can end up being part of my masking behaviours, and that's not always a conscious thing. So there is, again, that kind of sense of needing time that relationship with the person you're receiving support from to develop, so they can kind of almost see the full spectrum of you within being a part of the autism spectrum. They can also see you and like your different identities that form you as a person, whether that's your ethnicity, your religion, your gender or gender non-conformity. It can get very complex very quickly, and I think there's definitely scope or a need to develop tools to kind of facilitate mental health care providers in incorporating questions surrounding those things as part of the mental health support that they deliver. Yes, that's all I'm saying.
Absolutely. Brilliant, thank you. I think perhaps that's us at time now. So I'd just ask you to all join me in expressing our gratitude and appreciation to all our panellists today. Thank you.